I welcome you all for the webinar on Oncology Insights 2025. With immense pleasure, I would like to invite Dr. Ravi Tippeswamy, who is consultant in medical oncology at Spurge Hospital, Bangalore, for the welcome and introductory note. And to set the ball rolling, over to you, sir.
Yeah, hi. Good evening, all, and I thank the organizing committee and the speakers and audience for this program. So, in the next 2 hours or so, we'll briefly discuss how the changes have come with the recent ASCO updates and how we are managing, especially in breast cancer, supportive care, and what is the practice changing in the day-to-day practice. So I would like to invite Dr. Lokesh, who is a senior medical oncologist, to give his first talk. Over to you, Dr. Lokesh.
Okay. So thank you, Dr. Ravi, for that kind introduction. Oh, let me share my screen. I hope it's visible.
Yeah, yes, it's visible. Yeah.
Okay. So good evening, all. I would like to thank Dr. Ravi for giving me this opportunity to talk on newer updates in the management of first-line biliary tract cancer. So this is sponsored by AstraZeneca, and they have given the slides. So we all know that biliary tract cancers in India are around 30,000 odd cases as per the National Cancer Registry Program. And the incidence is more often we see in females. The gallbladder and biliary tract cancers highest in the states of Assam and Delhi, mainly in the region of River Ganges. That belt, actually, the incidence of gallbladder cancers are high. And also the gallbladder cancer incidence is very high in India as compared to other countries. And most of these biliary tract cancers are diagnosed in unresectable or advanced stage. So the treatment with the standard of care, that is gemcitabine cisplatin, the outcome is very dismal. The median overall survival, it's less than 1 year, and also a 5 year, it's less than 10%. It's very bad actually. So and also there is an increase in the trend of incidence of biliary tract cancers in both and males and females over last few decades. So as you can see here, the graph, the incidence is increasing both males and females. So what is the current management of biliary tract cancer? At present, we often use chemotherapy, that is gemcitabine cisplatin, that was continued to be the standard of care with no newer therapies for biliary tract cancer for almost 1 or 2 decades. Last 1 or 2 decades, we have not seen much advances apart from the chemotherapy gemcis. So this was based on the study called ABC-02 study, where it has shown the overall survival of 11.7 versus 8.1 months favoring gemcis, and PFS of 5 versus 8 months favoring gemcis. So versus gemcitabine alone. So that's all the survival we have seen. So it's hardly touching even 1 year overall survival with the use of standard of care gemcis chemotherapy. So again, we have other study. This is from India again. So they have compared gemcis versus gemox doublet in advanced gallbladder cancer. So in this, they have found overall response rate is little better with gemox. Median EFS is almost similar. Median OS is almost similar. So means to say, the gemcis or gemox, it can be interchanged and can be used as an initial regimen for advanced gallbladder cancer. And when you have a side effect like peripheral neuropathy or hepatotoxicity, so we tend to favor using gemcitabine cisplatin, and it has a high EFS and a lower cost. And about gemox, it has lower incidence of hematological toxicities and very potential ease of administration in patient with borderline renal and cardiac function. That all favors the combination of gemox chemotherapy. So this is the NCCN guidelines in 2022. That was pre-IO era. GEMSIS was the category 1, was the only category 1 preferred regimen for biliary tract cancers, apart from other category 2 indications of other combination of chemotherapies. So now about immunotherapy in first-line advanced biliary tract cancers. So this is a TOPAZ 1 study, a phase 3 randomized, double-blind, placebo-controlled study of durvalumab in combination with GEMSIS in patient with advanced biliary tract cancer. Mainly the sites included were mainly it's from the Asia. Most of the patients were from the Asia. I'll come to that. So this is the study design. Inclusion was locally advanced or metastatic biliary tract cancer. The BTC include intrahepatic cholangiocarcinoma, extrahepatic cholangiocarcinoma, and gallbladder cancer. And those who have recurrence more than 6 months after the curative surgery or last dose of adjuvant therapy with serum bilirubin less than 2 times upper limit of normal, ECOG PS of 0 to 1, more than or equal to 1 measurable lesion as per the RECIST 1.1 criteria. So it includes the cancer of ampulla of Vater. It's the patients were randomized in a 1:1 fashion, around 685 odd patients. So for gemcitabine plus cisplatin with or without durvalumab. So durvalumab given, it was every 3 weekly. And these patients were continued on durvalumab maintenance. The median primary endpoint was overall survival, with several secondary endpoints like PFS, overall response rate, duration of response, and patient-reported outcome, safety, biomarker analysis, and PK analysis. This is the patient demographics showing the characteristics in 2 groups. Median age was around 64 years in both the groups. Majority were Asian, as I said. Asian was 54% of the patients were Asians. And with intrahepatic cholangiocarcinoma was the predominant primary tumor, around 55%. Then followed by the gallbladder, it was 25%, and extrahepatic cholangiocarcinoma was around 18 to 19%. So intrahepatic cholangiocarcinoma was the most common primary type, and most were initially unresectable and metastatic disease. So MSI was done for half of the cases. In that, hardly it was positive, less than 1%, and few cases were positive for hepatitis, and PD-L1 expression more than 1 for around 57 to 59% of the cases. So again, this is related to the treatment, ongoing treatment. At data cutoff, it was 18% for durvalumab and only 5% for chemotherapy. So this is the different reasons for discontinuation, and patient received subsequent anti-cancer therapies. The reason for discontinuation, actually it's less with immunotherapy arm, and also the subsequent anti-cancer therapies was also less in the immunotherapy arm. So this is the overall survival. You can clearly make out the separation of the curve. Around 6 months it starts, and it shows statistically significant difference. Up to 2 years, it is 23.6% versus 11.5%. Almost 12% difference with the tail of the curve. It is flattening, and we can see it is the OS 12.9 versus 11.3 months, showing there is a significant benefit, sustained and durable overall survival benefit. And it was the first and only approved IO combination to show 2 years sustained and durable overall survival benefit, favoring durvalumab plus GEMSIS. So this is the again subgroup analysis with respect to overall survival, showing the benefit in all the different subgroups, whether you take in all the patient with a different sex and age at randomization, it's showing the benefit irrespective of PD-L1. It has shown the benefit. And the one point I wanted to highlight is that you can see the extrahepatic cholangiocarcinoma has shown the very good benefit as compared to the intrahepatic or gallbladder cancer. So the extrahepatic cholangiocarcinoma is the one has shown a very good benefit. Apart from that, you can see that the locally advanced disease again is showing the good benefit. So what about the progression-free survival? Again, the Imfinzi, that is durvalumab plus gemcitabine, also demonstrated a statistically significant and superior PFS against gemcitabine cisplatin alone. It was 7.2 versus 5.7 months, favoring durva plus gemcitabine with clear-cut separation of the curve. So means to say the durva plus gemcis is better than gemcis combination chemo. Again, with different subgroup analysis with respect to progression-free survival, showing clear-cut benefit in all the subgroups with respect to progression-free survival, especially in patient with recurrent setting. And as I said, with respect to overall survival, also with PFS, there is a clear-cut more benefit with extrahepatic cholangiocarcinoma and locally advanced disease. So that is what the durvalumab is better in biliary tract cancer, but extrahepatic cholangiocarcinoma has a more benefit than other two subtypes. So not only the survival, the Imfinzi plus gemcitabine also showed a significant response rate with 1 in 4%, 4 patients remaining in response beyond 1 year. So this is what the overall response rate 24.6% versus 18.1% with around 2% of the cases showing a complete response. This group of the patients are going to attain the durable responses and gain the maximum benefit, and I think that will add up to the benefit with hazard ratio when it comes to the survival. So you can see at more than 12 months with durva gemcitabine it was 26.1 and it was 15 with respect to the response rate and disease control rate. And the duration of response, again, you can clearly make out the duration of response is better with durva gemcitabine as compared to the chemotherapy only combination. So what about the patient who have responded and those who have not responded? So we can see here the first above curve, the yellow and blue one. You can see these are the patients who have achieved complete responses. So around 15 months, the curve separated very widely. So these are the group of patients who have achieved complete responses, and they have shown clear and sustained separation of the curve beginning approximately 15 months after randomization. So if the patient achieve complete response after 15 months, they are going to show the clear-cut benefit with respect to overall survival. Similarly, like that, the patient who have achieved stable disease at around 6 months, it's around 6 months the curve separates. So that shows the patient who have achieved stable disease around 6 months. We can clearly see the sustained separation between the curves at approximately the 6 months in patient with stable disease. So this is a complete response. This is stable disease. Of course, these are the progressive disease patient, not much difference. So this is the one, the addition of durvalumab to gemcitabine was well tolerated and very safe when it comes to the toxicity profile. And you can see that any treatment related adverse event leading to discontinuation was only 8.9% with immunotherapy and 11.4% with chemotherapy. And death, again, it was very similar. And any grade 3-4 immune-related adverse events, 2.4 with durva arm and 1.5% with chemotherapy arm. So these are the different adverse events. So most of the adverse events were related to chemotherapy combination, and these were easily manageable. So you can see the majority of the patient anemia was around 22 to 23% in both arms, and nausea, constipation, neutropenia, they are all similar between the two groups with not much significant difference when it comes to all the toxicities. With addition of durvalumab, it's well tolerated, and most of the side effects are driven by the chemotherapy combination. So this is again the safety and toxicity of adding durvalumab to chemo. So most common grade 3-4 adverse events were anemia, neutropenia, and decreased neutrophil count. So you can see here durva and gemcitabine, it's actually less of neutropenia as compared to the chemotherapy. And again, anemia, it's almost similar. So it's almost similar with adding durvalumab. It is not causing much increased toxicity. So what about the immune-related adverse events? So these events are usually low and less than 2.5% of the patient experience grade 3 or more immune-related adverse events. So most common adverse events, what was seen was actually the thyroid-related. So hypothyroid events were more common and skin-related, especially the dermatitis rash. So rest all, it's 1% or even less than that. So all showing the immune-related adverse events are very less than 2.5%, and majority are grade 1 or 2, and those are all can be easily identified and can be managed with the regular treatment as per the toxicity criteria management. So what about the overall survival in patient who have developed adverse events, immune-related adverse events, and without immune-related adverse events? Again, it is showing the benefit whether the patient develop adverse events or not. So the benefit was seen with addition of durvalumab to Gemcis, irrespective of the immune-related adverse event. So based on this study, the NCCN guidelines recommend durvalumab plus Gemcis as a category 1 indication for patient with primary treatment of unresectable or metastatic biliary tract cancer. Or again, the patient who have recurred more than 6 months after surgery with curative intent, or more than 6 months after completion of adjuvant therapy. So there were no new therapies for more than a decade. Now, since last decade, now 2023, durvalumab plus Gemcis is the category 1 recommendation for biliary tract cancer. So very good addition for the patients who have not seen much benefit in the last decade. So to conclude, durvalumab plus Gemcis demonstrated statistically significant and clinically meaningful prolonged overall survival as compared to placebo plus Gemcis. Biomarker status, durva plus Gemcis appear to be effective across the molecular landscape of BTC, and patient with targetable genomic alteration benefit from durva plus Gemcis. And durva did not add additional toxicity to that seen with chemotherapy, and no new safety signals were identified. DCJ approval, durvalumab 1500 mg in combination with chemotherapy is approved in adult patient with locally advanced and metastatic biliary tract cancer. So TOPAZ is the first global phase 3 trial to report positive results with immunotherapy and chemotherapy as first-line treatment for advanced BTC, and could become new standard of care. We are already using it, and it is the new standard of care. Thank you.
Yeah, thanks, Dr. Lokesh. How is your experience with the Durva?
Yeah, durva, we have actually very few patients we have used. So we have got some good responses for 2 patients. So for almost a year, they have done well. So, but actually, we have not seen as good responses we've seen with durva in other indications.
Yeah, but since we don't have much option, it's a very aggressive
Yeah,
disease,
yeah.
and subgroup analysis, because we see both gallbladder and cholangio. I think it's since we don't have much option, with the available option, I think Durva and Gemcis should be the standard of care.
Yeah, definitely. And it has shown more benefit in extrahepatic cholangiocarcinoma
True.
than intrahepatic or gallbladder. So it has seen the benefit in all the three, but benefit was more in extrahepatic cholangiocarcinoma.
Yeah. And another peculiar this one, what we have noticed is unlike PD-1 inhibitors, these PDL-1 inhibitors have got less toxicities. We hardly
Yeah,
encounter, yeah,
definitely.
that's one more good
Definitely,
thing
I
because,
agree that durva actually the toxicity is less. Even with other PDL1 also we have seen the toxicity is less as compared to the PD1. Maybe it is the only the ligand it inhibits rather than the complete PD1 receptor.
yeah. Thank you, Dr. Location. So
Yeah,
with this, I
thank you.
will call upon my next speaker. So Dr. Vijay, Dr. Vijay,
Sir,
yeah.
good evening, sir.
Hi, sir.
I guess, sir.
Yeah,
Good evening.
hi. Yeah, good evening. First, I
Sir,
think Dr. Vijay K will speak. It's
okay.
about unrestrictable HCC, how immunotherapies and TKs have changed the present line of management. Over to you, Dr. Vijay.
Thank you, sir. Thank you. Firstly, good evening, everybody. At the outset, I'd like to thank Ravi sir for giving me this opportunity to talk on the updates in HCC and what's the new treatment, the newer shift into the treatment paradigms. And if it's okay, can I just get some assistance in changing the slides, please, from the back end? Can I have my slides, please? Yes, thank you. So just let's kind of delve quickly into what's transforming patient outcomes with innovative therapy in advanced unresectable HCCs. Next slide, please. So we kind of have a in-depth overview on what's happening within terms of the incidence, and then we kind of look at what is the etiopathogenesis. Subsequently, we go into the standard of care. What are the newer guidelines, or rather, what is the existing guidelines? Subsequently, finish with the newer updates, and then my summary. So to start with, if you look at the incidence, globally, liver cancer is the fourth most common, whereas overall it looks like it's the seventh most common and fourth most common cause of cancer-related deaths globally. Next slide, please. And majority of the times, if you look at the 5-year survival, clearly if the disease is localized, you have around 31.3% 5-year relative survival as per early stages. But if you look at patients with regional as well as distant metastasis, which contributes to close to 45% of the patients, which is having a very poor or a dismal outcome with 5-year outcomes ranging somewhere between 2 and 10%. Next slide, please. So that which clearly says early diagnosis is key. And once patients have metastatic disease, the prognosis is going to be very poor, including lymph node mets. Next slide, please. And what's the ratio in India? If you look at it, the male to female ratio is 4:1. And the median age, if you see, it has a broad spectrum ranging somewhere between 40 to 70%. And almost our incidences and deaths is almost pretty much very similar to the global cascade. And also majority of the patients do present in advanced Barcelona clinical liver criteria staging as per the BCLC scoring. Next slide, please. And this is about what the etiopathogenesis is. We know inflammation is a key component which is responsible for transformation, where fibrosis gets transformed into cirrhosis, which is what happens over a period of time. And the common risk factors, which is again, you have these infective, you have metabolic syndromes, and ethanol, which is a proven risk factor over a period of time, cause significant cell death and cause significant changes in the immune milieu, causing proliferation and increasing the neoplastic, increasing the oncogenic transitions and pushing the patients into transformation into a hepatocellular carcinoma. Next slide, please. So again, it's the same cartoon, which kind of goes away from viral etiologies to substance abuse to metabolic problems. Eventually, there are a lot of other conditions as well. But of late, what is happening is that the more important ones, especially the existing ones, were always viral related HCCs, which was very well aware. I mean, we were more used to seeing these patients. But now what's happening is there is clearly a transformation change. Next slide, please, where the metabolic causes have become a lot more significant, like NAFLD and NASH and obesity. This is what we've been seeing, and clearly even our data, which was a study from AIMS, which looked at what was the primary etiology fractions in patients with HCC in India. We clearly see that there is a paradigm shift where we're starting to see a lot more non-viral etiology, which is again more in favor of NAFLD, the non-alcoholic fatty liver. The subgroup, followed by the ones with viral hepatitis, and then the ethanol, which eventually transforms into HCC. So clearly there has been a paradigm shift in the etiology, at least in our country. Next slide, please. So what's the management of advanced unresectable HCC? So if you look at our guidelines, so primarily, the primary area of interest right now is in the advanced stage where we're looking at, which is the BCLC B and above. So in the advanced stage, which is BCLC C, what we do is what is here. So if you look at it, the systemic treatment for these patients, that is, we're talking about patients who has disease outside, which is unresectable, or patients having disease in the lymph nodes or metastatic. The standard of care has been atezolizumab and bevacizumab, and we've also had some data with Himalaya approving the Durva-Tremi. And in the second line you have a armamentarium of drugs, let's not delve into these. So this is where we are. So next slide, please. So this is how the whole evolutionary shift has happened in HCC, starting from 2007, where we had sorafenib. Then eventually you didn't, for another decade, you really didn't have any other drugs. And then is when regorafenib came in the second line. And then in the first line, you had lenvatinib and single agent pembrolizumab, which was approved based on brilliant responses. Response rates were close to 25% in the phase 2 study. And then subsequently, you had atezo-bev, which is the new standard of care, which I'm going to talk about in the subsequent slides, followed by the dual IO, the CTLA-4 plus IO combination. And then we have Tremi with Durva, which had approval in the second line, in the first line in 2022. Next slide, please. So what's the evidence for approval of lenvatinib? So sorafenib versus placebo in the SHARP trial definitely had a significant improvement in the overall survival. Likewise, REFLECT was the study which was responsible for giving us an improvement in overall survival in the first line when it was compared over sorafenib. So this was sorry. I would just request somebody at the back end to mute their mic, please. Next slide, please. So if we get into the detailing of what is happening with immune checkpoint inhibitors with anti-VEGF, we're primarily going to talk about atezo-bev. Next slide, please. So atezo-bev, the study which is the study called IMbrave 150, which was a phase 3 study which primarily looked at atezo-bev versus sorafenib, which was a 2:1 randomization. And the primary endpoint was overall survival, and the key secondary endpoint was overall response rates. And next slide, please. So the inclusion criteria was stiff, and more importantly, this had patients from both Asian as well as non-Asian ethnicity. And when you clearly see here that there is a wide separation of curves, and also the separation of curves is starting off very early, starting from the second month, which is again more promising, which is what we see in clinics. So the median overall survival is around 19.2 compared versus 13.4 to the comparator arm. A clear 6 month, or rather somewhere close to 5-6 month benefit in overall survival with a hazard ratio of 0.66. Likewise, if you look at the PFS, clearly another additional 2.5 month benefit with a very strong hazard ratio of 0.65 in patients with unresectable HCC. Next slide, please. And when we kind of look at the subgroup analysis to kind of dissect out where the significant benefit seems to be, it's clearly in this subgroup, which is viral driven HCC. So the infective HCC seem to get a significant benefit with atezo-bev, whereas the non-viral HCC, which is the group what we normally see predominantly in India, again, the NAFLD associated, metabolic syndrome associated, seem kind of not to benefit significantly overall. Again, mind you, this is a subgroup analysis. The study is not powered to answer this question, but somewhere this has been a very common discussion point for most of our decision making over a long run. Next slide, please. And when we look at the toxicity profile, I'm sure everybody is aware of. We've not seen anything new. It's pretty much the same. The proteinurias and the hypertensions which kind of come in because of the VEGF inhibitor, along with a mild amount of loss of appetite and diarrhea. Next slide, please. So even in clinics, we've seen that it's a really well-tolerated regime. Next slide, please. So next, talking about what the dual checkpoint does is primarily along with the anti-PD-1 or the PD-L1 inhibitor, we're also adding another drug called CTLA-4. So this is basically you're trying to activate the lymphatics, activate the lymphatic components or lymph node components to increase the number of T reactive cells. Thereby, you create a synergistic environment and you make the microenvironment more cohesive, and thereby you're making it prevent T cell inhibition. Next slide, please. So this is again the same story. What Durva and Tremi, what it does is primarily it mainly acts by reversing the T cell exhaustion and also by allowing the T cell activation. So this is the same key component which is responsible, where what Durva does is primarily it goes and blocks the PD-L1 and it's reversing the T cell exhaustion. Whereas tremelimumab, what it does is primarily acts in the lymph nodes, the CTLA4 inhibitors, thereby it mainly acts by allowing the T cell activation. Next slide, please. So this is something which we've learned with time, where we found that one single dose is primarily sufficient. What happens with CTLA4 is this one single dose of CTLA4 is sufficient to cause a significant burst of the peripheral T cells, which we've kind of very clearly seen in studies from non-small cell lung cancer. And also in melanoma, we've seen that continuing the CTLA4 beyond the first cycle, there don't seem to be a significant benefit. And also, the burst of peripheral T cells, which is usually seen at the first cycle, is not seen in the subsequent lines of cycle, which is what makes the whole concept of why not do just one cycle of CTLA4 upfront to cause the peripheral burst of T cells and then continue prolonged immune suppression or continue prolonged breaks on the T cells and activate your kind of immune system to mount a response, which is what your prolonged anti-PD-1s or PD-L1s do. So this particular combination of CTLA4 one dose plus continuation of a PD-1 or a PD-L1 inhibitor has been the new norm, which we've kind of learned from the lung studies, where Checkmate 9LA was one such primary study which explored that option. So that was the same concept which was also extrapolated into this particular study, which was the Tremi-Durva study, where they said, okay, single dose of tremelimumab, I think should still be okay, because you're getting the maximum benefit and you're continuing to keep the brakes on and also result in a good clinical activity in patients. The most important thing is also you're minimizing the toxicity, because we know CTLA4 is pretty notorious. It's known to cause a significant amount of toxicities as you continue. So using a low dose, single dose is a good strategy. And this is what was kind of extrapolated into the subsequent studies. Next slide, please. So this was the phase 2 study. Without further ado, I will move into the phase 3. This was primarily to look into the PK/PD, and they realized that the dose of 300 mg is sufficient. Low dose, the stride regime, which is the Tremi 300 mg, the first dose, one dose, followed by Durva 1500 mg once a month was the standard what they kind of chose for phase 3. Next slide, please. So the safety was good, safety was manageable, and then this was next slide, please. So even in phase 2, the data was very significant, which led to kind of the third line, which is called the Himalaya study. So which was a phase 3 open-label multicentric study. Again, mind you, this had patients across the globe. It had patients from Asia and non-Asia. Taiwan and Korea were the centers which kind of contributed significantly. Next slide, please. So this was a 4-arm randomization study. The arm A was primarily the STRIDE. So again, STRIDE stands for single tremelimumab, and then Durva, which is given episodically. Along with there was also another arm which said durvalumab monotherapy. There was an arm for sorafenib, and the fourth arm was eventually dropped because they planned for doing 4 doses of tremelimumab, which eventually was kind of taken off and then made it as a single dose. And the inclusion criteria was pretty stable, was pretty common, and also had patients with macrovascular invasion. They did kind of stratify if there was a benefit between the two, where with the primary endpoint being overall survival. Next slide, please. So this is the same consort where it's looked at how frequently this is given. So a single priming dose of tremelimumab plus 1 dose of Durva given once a month, or rather once 4 weekly was what was considered. Next slide, please. So if you look at the patient demographics across the 3 arms, it looks like pretty much the same. It had a good proportion of Asians being representative, viral versus non-viral. Close to 60% had viral, and another 40% had a good non-viral histology. And when you look at the key point here is to look at the macrovascular invasion. So somehow this study is not included a significant number of patients with macrovascular invasion. It's around, say, 1/4 of patients. And they also wanted to explore if PD-L1 positivity was that of some kind of a significance. And also it clearly has patients who had significant amount of extrahepatic spread. Nearly more than 50% of patients had extrahepatic spread at the time of recruitment. Next slide, please. So when you look at the subsequent second line of anti-cancer drugs, if you see only 40% of patients across subgroups went on to receive any other subsequent line of therapy, which also goes to kind of re-emphasize the point that these patients or patients with metastatic or advanced HCC, you only get one shot at treatment, and you have to get your best regime upfront, and your probabilities of having a second shot at these cancers are usually smaller and smaller. Even in the best of the best chosen clinical trial patients, you have only around 40% of patients who are actually getting subsequent lines of therapy. Next slide, please. Sorry. So when you look at the overall survival, again, this is something which we clearly have to see. It's taken a little longer time if you look at the curves closely to start with. So the separation of curves starts somewhere around 6 months. So this is again a little bit of what we see with immunotherapy drugs. It takes a little longer time to kind of see those responses. But if you look at it, the median overall survival is very significant. It's somewhere close to 16.4 versus 13.8 with a hazard ratio of 0.78, which clearly says a 22% reduction in the risk of death compared to sorafenib. Again, for sure, we are never going to get a study which is going to compare atezolizumab versus durvalumab. So this is what is available as of now. So compared to the present or the existing standard of care at that point, you clearly see at 3 years as well, there is a good 10% improvement, or rather a 10% chances of improvement in overall survival clearly. Next slide, please. And this is again interesting when you look at the subgroup analysis. The viral seem to benefit, but what is more important is the non-viral, especially the non-viral, what we mean by the NAFLD or the metabolic syndrome causing HCC. This is a niche subgroup where, I mean, this is a regime which has shown a lot more promise in the non-viral histology. So that's a positive answer for us to kind of take it, because that's a subgroup which has been more resistant and refractory to treat. Probably the CTLA4 plus the PD-L1 inhibitor is a good combination to consider in this particular subgroup especially. Next slide, please. And the median duration of response, again, reiterating the same, clearly overall responses or the overall response rate is very good, 20% compared to 5%. And in patients who respond clearly, they do well. This is again a no-brainer. As oncologists, we've seen this patterns. So it's like a lottery ticket. If you kind of win the lottery ticket, you continue to do well. But it's just that there is no way to identify who are the ones who are going to win the lottery ticket. The probabilities are so low that we've still not been able to identify a specific biomarker to isolate these patients and kind of cherry pick this patient population and feed them with immunotherapy so that you can keep them alive for a long periods of time. Next slide, please. Saying a little bit of toxicity is pretty much the same, nothing new, because it's just one dose. You clearly see that the toxicities are pretty much manageable. And if you see the grade 3 or grade 4 toxicities, it's around 12%. So which again goes to say that we've kind of gotten well acquainted in treating these and identifying patients where by giving just one dose, you minimize the toxicities and pretty much comparable to with both the arms. So there are no new signals which they kind of found out with this particular regime. Next slide, please. Next slide, please. There's nothing to differentiate. Pretty much the same toxicities what you see with IO, rash, pruritus, diarrhea, what we've seen with the combination. Again, the CTLA4 comes in primarily for all the skin toxicities. Next slide, please. And also, this was something which is very important to note, that there was no increased risk of bleeding, because the primary reason why they've kind of put this is because with anti-VEGF inhibitors, there is always a slight increased risk in bleeding. So here, you don't see that increased risk of hemorrhages. And also esophageal varices were almost never reported in the study. Next slide, please. So following this is where the NCCN 2024 has kind of given them a level 1 approval, category 1 rather, cat 1 approval for this combination. Next slide, please. So with this, I would like to conclude. So it is one of the top most common cancers affecting Indians. There's clearly a shift in the etiopathogenesis from viral to non-viral. Immuno has always been a significant, it's been a strong armor for us in treating these patients. And atezolizumab has been the new standard of care. With this recent data, clearly one dose of tremelimumab with durvalumab is something what we can clearly consider. And there is a significant benefit across subgroups for the CTLA-4 IO combination, especially in the non-viral patient subgroup, with a very low rates of discontinuation in GI hemorrhages. With this, I would be happy to take any questions. Thank you so much.
Yeah. Thanks, Dr. Vijay, for that wonderful discussion. Now, with the availability of two IO regimens, how we will choose between these two?
So, sir, actually, I mean, it's a very good question. So, how I'm doing it in practice is, so if we look at atezo-bev, so what is very important is it's important to understand that patients with VP3 and VP4, which is again main branch thrombus, as well as a portal vein thrombus, nearly 40% of patients were included in the atezo-bev arm. So, and the data is very strong there. So, if patients have, say, portal vein thrombosis, especially VP3, VP4, I am more inclined in the atezo-bev regime. And when you look at, again, viral etiology, clearly no-brainer, atezo-bev is superior. And if it is a non-viral etiology, then I am more towards the IO-IO combination, EP plus Nivo versus, say, atezo, versus what we spoke, Tremi with Durva. So between the two, choosing it, if you dissect that out, so there is again, the number of patients who had VP3 and VP4 are slightly more higher in the EP-Nivo subgroup. So patients with major vascular invasion had, it was part of their inclusion criteria, and they had more patients. So if patient has a portal vein thrombosis, then I am more inclined in doing, say, EP-Nivo compared to atezo-bev or even Durva-Tremi, because it was only 25% in this. And also VP4 was a strong exclusion criteria. That is, the main portal vein thrombus was an exclusion criteria in the Himalaya, in the STRIDE regime, basically. So this is how I differentiate between the two.
Yeah, but in general, what has happened is this Ipinivo probably not yet still popularized, and atezo-bev we were using since many years, but presently Durva-Tremi, how we have seen is, especially if the patient has portal vein thrombus or not portal vein thrombus, is esophageal varices. That is one significant criteria, because many of our patients do have esophageal varices, and this is one regimen which is way to go. And regarding viral and non-viral, I think it's a subgroup analysis, so we should not conclude and take it at face value. I think between two regimens, both are good regimens. But since our patients have a lot of varices, I think Durva-Tremi is also a very good regimen, because Tremi is only one dose and Durva is monthly once. So I think it is one of the easier regimen to administer. So thank you, Dr. Vijay.
Dr. Ravi.
Yes, Dr. Srinivas. Yeah.
Dr. Vijay, I think they have done a meta-analysis now. The meta-analysis shows that atezo-bev is not a bad regime even for a non-viral. Mayer et al. Mayer et al. Has done a meta-analysis which was presented in ASCO 2025. There they say initially it was thought that that cohort, non-viral cohort, may not do good with atezo-bev. But as Dr. Ravi rightly said, patient with have a bleeding tendencies, patient is having active bleeding. Definitely, BAVE, we get that fear factor is there. We cannot use it, BAVE, because of there may be more active bleeding. I think definitely Tremi Durva will definitely do the upper hand in the regime has upper hand in those settings. But that non-viral, since it was just a subgroup analysis in this trial, but a large meta-analysis has shown they also do better.
No, clearly I agree with that, sir. Clearly, yeah, I remember seeing that the meta-analysis showing that benefit. I totally agree with that. One other point which is of primary importance is portal vein thrombosis. So patients with portal vein thrombosis, again, your data strongest is for atezo-bev. Across studies, if you look at it, this is the only study which is taken in patients even with VP4. And most of them have been very careful in leaving them out. But one group where it has a niche, clearly, like Ravi sir pointed out, esophageal varices is a concern. Majority of our patients are going to have that toxicity.
I had one patient who had a rectal varices actually. Initially, it was not shown. It was very mild. Then gastroenterologist, I took opinion. They told you can go ahead with atezo-bev. First 4 cycles, I didn't have any problem. 5th cycle, she had a very severe bleeding, rectal bleeding, and the mom immediately we stopped. We had to stop. There was no choice. And of course, since they had a Atiso program, they opted for single agent Atiso. After that, I offered them Tremi Durvo, but they were not willing because of financial issues, of course. So I think definitely those subsets, Tremi Durvo would definitely be, as an onco physicians as such, we ours will feel better to give a non-BAVE containing regime. Because
I
we
think
don't
it's a very
know,
valid point.
they may knock the
Ipinivo,
door.
yeah, Ipinivo somehow still not yet popular in HCC.
True, sir.
Yeah.
And Ipi-Nivo is also not very easy regime to tolerate. There are some challenges. We have seen in RCC, we have seen Ipi-Nivo, so we have burnt our fingers. It's the toxicity profile is not that easy.
True.
Because see, in Ipi-Nivo, you are not going to give one injection just like stride. There you are going to give a continuous. Isn't it, Ravi? I think
Yes.
Ipi-Nivo.
True. Yeah, at least 4 doses of EP.
4 doses at least Ipi will go.
Yeah.
Thank you, and I thank for those updates. I will like to invite Dr. Srinivas for the updates in breast cancer. Over to you, Dr. Srinivas.
Thank you, Dr. Ravi, and for giving me this opportunity to talk on this wonderful forum. I would like to share my screen. Is my slides are visible, Dr. Ravi?
Yeah, visible. Just
Full
make it
slide?
visible.
Is it full slide? No?
No, not full screen. You have to make it.
Is it now full screen now?
Yes, sir. Yes.
Yeah. Now it is.
Vishal?
Yes, sir. It's full screen.
Is it moving?
Yes, sir. Moving.
Hi. Okay, Dr. Ravi has asked me to talk on this topic, which is one of the very important topic, and it was presented in ASCO 2025 plenary session. Of course, anything which comes new in gastric cancer is something very important. We all look forward for anything new because we all know that whatever we do, gastric cancer patients, metastatic or rather the life's overall survival is not more than a year and a half. So whatever we had to do something, it's in early stage or a locally advanced disease, because whatever the benefit they get, that is the best benefit they get upfront. And if they get into advanced disease or stage 4, their survival becomes very poor, whatever the therapy we give. So hence, any improvement in resectable disease or early stage or a locally advanced disease, I think that is something very credible, I believe. So one such study called Matterhorn study was presented in this ASCO, and this abstract was selected as a plenary abstract. So I'm going to present this data. Event-free survival in Matterhorn, a randomized phase 3 study of durvalumab plus 5-fluorouracil, leucovorin, oxaliplatin, and docetaxel chemotherapy, which is popularly called as FLOT, in a resectable gastric or gastroesophageal junction cancer. So the key takeaways, generally what happens in all the ASCO abstracts, first slide would be the key takeaways, which is actually good in a way that what is a summary in a nutshell. So the addition of durvalumab to FLOT improved EFS in resectable gastric and gastroesophageal junction adenocarcinoma. So now we know that Matterhorn study was a positive study, and it did improve the EFS when in addition to FLOT, which we generally give only a FLOT. All these days we used to give only FLOT regime in resectable or inoperable, for that matter, gastric cancer. But this study was mainly done in a resectable gastric and gastroesophageal junction tumors. So the background is 1.2 million people will die of gastric and esophageal cancer in 2024, which means it's a very unmet need. There is a lot to do more in these sort of patients. And FLOT chemotherapy, which is the gold standard until now. So 5FU, leucovorin, oxaliplatin, and docetaxel improve survival when combined with surgery for localized gastric and GE junction tumors, but many still suffer from recurrence. This is the problem in gastric cancer. Many of them, they recur, so something has to be done more. So adding anti-PD-1 therapy to chemotherapy improves survival in metastatic GEA. Its role in perioperative setting, however, remains uncertain. Matterhorn, for the first time, evaluated whether adding a PD-1, this is the first anti-PD-L1 antibody to be tried in with a chemo combination in resectable gastric or G-junction tumors. So Matterhorn evaluated whether adding darolutamab to FLOT improves outcome in patients with resectable localized gastric or G-junction adenocarcinoma. So this is the study design. It's a global phase 3 randomized double-blind placebo-controlled study. So the population was, it should be either gastric or G-junction adenocarcinomas with stage 2 to stage 4A. So as I told you, it's a operable or locally advanced tumors. No evidence of metastasis with and no prior therapy. Patients has to be naive and with a good performance status, and global enrollment happened in Asia, Europe, North and South America. The stratification factor was Asia versus non-Asia, node plus or node negative, and of course PDL1 less than 1% or more than 1%. I'm going to come to that later. So these patients were randomized in 1:1 fashion. Around 948 patients were there in this study. Patients were randomized to experimental arm where there was a neoadjuvant 2 cycles of darolutamab 1500 mg every 4 weekly was given along with FLOT, and in the standard arm 2 cycles of FLOT with placebo was given. Then both the groups underwent surgery. After surgery, in the experimental arm, darolutamab was given up to 1 year. Essentially, first 2 cycles with FLOT, again followed by 10 cycles of darolutamab as a maintenance. In standard arm, two more cycles of FLOT to be given. After that, placebo. So FLOT 2 cycles means day 1, day 15. So the primary endpoint was EFS, secondary endpoint was OS and pathological complete response. So the primary endpoint EFS, time from randomization to event or death, which was tested at 41% maturity, and the key secondary endpoints like overall survival, which is an interim analysis at 34% maturity with minimal alpha spend, final OS ongoing. And they are also looked for the pathological complete response, which means no residual viable tumor in the primary site and nodes at the time of surgery. So the secondary endpoint was disease-free survival, that is time to disease recurrence or death in participant with R0 resection. So there are multiple testing procedure and alpha allocation. So this is the baseline characteristics, and if you see that with the patients in neoadjuvant, almost like 97% of patients completed darolutamab, and 95% in the standard arm could complete FLOT. And in both the groups completed any FLOT, like around to the tune of 95 to 96% respectively. And the surgery was attempted in 91% in darolutamab plus FLOT arm versus 90% in FLOT alone arm. If you see the R0 resection, it was same in both the groups, 92%. I'm going to come to pathological response in the later slides. And if you see percentage of adjuvant treatment was completed darolutamab in 52% of darolutamab plus FLOT group and 52% in FLOT alone group. And active follow-up at the data cutoff was 68% in darolutamab arm and 59% in chemo alone arm. This is the baseline characteristics. It was very well matched for both the groups. Either it's a performance status or the site of tumor. If you see, majority of them were gastric cancer in both the groups, and around 32% in G-junction site. And if you see T4 lesion was seen in 25% in both the groups. And if you see the node positivity, it is 69% in Darvo and 70% in FLOT alone group, pretty similar in both the groups. And if you see the histology type, it is intestinal in 52% in Darvo and 50%, which is again pretty similar. And diffuse histology 27% and 25% respectively. If you see MSI high, so both the groups had around 5% of patients who had MSI high patients. So the primary endpoint of event-free survival, the primary endpoint was met. A statistically significant improvement in EFS was observed with Darvo with FLOT compared to placebo with FLOT. If you see the median EFS, it was not reached in durvalumab group versus 32.8% in FLOT alone group. The hazard ratio favored durvalumab plus FLOT, which is 0.71, where they could do HR 0.7 means 29% reduction in death at the time of data cutoff. The p-value was again very significant. If you see the 24-month EFS rate, it was 67% in durvalumab plus FLOT versus 59% in placebo plus FLOT. So significantly telling the curve clearly says that there is an early separation of the curve, and it is sustaining. Like it goes till like 24 or 36 or 48 months, saying that patients with durvalumab plus FLOT did definitely better as far as the EFS is concerned in this study. Again, this is a subgroup analysis and which is consistent benefit across the group observed, whether it's male or female, less than 65 years or more than 65 years. Whether it is node positive or node negative, both the groups did well with durvalumab plus FLOT, and in both the locations, whether it is gastric or G junction, and across the histology types, all the subgroups did better with durvalumab plus FLOT compared to FLOT alone. And if you look at the hazards, it is 0.7, 0.74, 0.70, 0.69, pretty convincing hazards with a good confident interval. Again, if you see the endpoint of overall survival, it is not matured yet. P-value was not significant. We cannot comment this because still we need more maturity to comment on OS. I think over a period of time, this will be answered. But there is a trend in improving survival in durvalumab plus FLOT, as you can see. The curves getting separated like from 15 months onwards, and it's sustaining. The separation is there still till the end, till you can see the tail. Still, it is separated. So saying that there is a trend in OS, but we need still mature data to comment on OS. If you see the PCR, a statistical significant improvement with the addition of durvalumab to FLOT. The PCR rate was around 19% in durvalumab plus FLOT compared to only 7% in FLOT alone group, suggesting that there is almost like more than 2.5 times higher PCR rate compared to FLOT alone in this group. So again, if you see the DFS improved with durvalumab plus FLOT versus placebo in those with R0 resection as well. So patient who had a R0 resection, so they also did they had a better DFS compared to placebo plus FLOT, which is 39.8 months, and a hazard ratio of 0.70 was seen, saying that again the DFS was better with durvalumab with FLOT group. So the number of neoadjuvant cycles of durvalumab plus FLOT or placebo plus FLOT was more or less similar. And if you want to know about toxicity profile, the adverse events, they were pretty more or less same. And if you talk about grade 3 adverse events, it is 7 and 4, pretty more or less same. And immune-related adverse events were higher, obviously, because durvalumab plus FLOT contains an immunodrug, IO drug, whereas FLOT contains only chemo drug. So naturally, immune-mediated adverse events will be little more higher in durvalumab plus FLOT compared to FLOT alone. So otherwise, more or less, the toxicity profile was more or less same because of the chemo. We all know that we are well versed with the chemo part of it, and we know how to handle this. There was no new concerns identified with the durvalumab and FLOT. So these are the common adverse events: diarrhea, neutropenia, nausea, alopecia, fatigue, vomiting, pretty more related to the chemo component. And only few component like rashes and all those things were seen in as a part of immune-mediated adverse events. So in conclusion, durvalumab with FLOT significantly improved EFS versus FLOT alone in resectable gastric and G junction adenocarcinoma. The EFS benefit was consistent across subgroups and geographic regions. No new safety signals concerns were identified. and OS data are encouraging, and final OS analysis is still pending. We want more mature data to analyze this. So Matterhorn supports global adoption of perioperative durvalumab with FLOT as a new standard for patients with localized gastric and gastroesophageal adenocarcinoma. So I think for the first time, the immune drug, IO drug, has entered a perioperative space in gastric and G junction tumor. I think from now onwards, I think we are going to see more and more IO interventions in early stage gastric cancer. I think, as I told you, any novel drugs, any novel approach to improve the EFS and OS in gastric cancer is something very commendable, because we don't have much options in gastric cancer. Once they progress, the options become very less and they don't have great hopes after that. So I think whatever we can do best in an early stage or resectable stage or a local advanced stage is something very, very valuable, I believe. Thank you.
Yeah.
And this is the new NEJM publication where they published this perioperative durvalumab in gastric and G junction tumor. It got published recently in NEJM.
Yeah. Thanks, Dr. Inas. I think this is really practice changing.
Yeah.
But with genomics coming into picture, and if the patient has HER2 positive or Claudin, how do you see future? So presently we are not using in the perioperative setting.
So if you see the subgroup, irrespective of PDL1, actually these patients did well. Well, the TAP scoring less than 1 or more than 1, I don't know, I forgot to highlight, I believe. If you see the subgroup, irrespective of PDL1, actually Durvo plus a FLOT did better, both in positive and negative group. Definitely Claudin 18.2 is something very interesting, but I think we want to have data probably down the line that will answer. And nowadays a lot of ADC targeting Claudin 18.2, it's also coming. There are a lot of papers in ASCO which is ADC which is targeting Claudin 18.2. So I think but it is that is in metastatic setting. I think doing something in perioperative setting is also something what we have learned in AGN, Durvo plus chemo in lung cancer. Now we are I think a lot of perioperative regimes are getting changed, and if it can show a survival benefit, definitely I feel this is going to be a game changer. I think OS will throw more light. OS data will throw more light on this regime. And the one thing what Ravi I want to highlight is Durvo is something what we know is very tolerable. It's not a toxic combination. Durvo with FLOT, something we can definitely manage even on OPD basis, the toxicity, and I think a very relatively patient-friendly regime. The toxicity issue is also not there. A very easy drug to give, and if it can give a OS benefit, definitely I think that would be a fantastic regime in armamentarium.
True, I agree. I think esophagus and G junction are very notorious for relapse, whatever we do. And even we have seen, even with PAT-CR, they tend to do relapse. So if you are giving some medications where like maintenance, especially, I think that is a way future for all early cancers.
Exactly. So now I think fortunate we are all as an oncologist, we are witnessing a new trend. Everywhere there is a HER2 space. Everywhere there is a perioperative space. And now in gastric 18 Claudin based drugs, Claudin targeting drugs. I think this stratification is getting better, and we are trying to understand which subset. Not all the patients are doing good with all the regimes. I think in lung, what is it that the lung is clear winner because it has paved a way. I think this particular subset of patients will do with this path. I think when you segregate, when you bifurcate things vertically, and when you know the subgroups, these are the subgroups which are going to do better. I think things are getting evolved, and definitely we have all seen that gastric cancer patients are very notorious to relapse, and they don't have much to do later after in a metastatic setting. Probably we don't have much. We have a Neo with FOLFOX again, not a very greater future there. Also, they don't do for long. I think anything which has to be done, it has to be early stage or local advanced stage. And if this drug, as I told you, can give a OS data, definitely it's a very encouraging regime.
Thank you, Dr. Srinivas, for that wonderful discussion. I will next call upon Dr. Vijay Simha to talk on dual blockade in breast cancer, HER2 role, especially dual blockade. Over to you, Dr. Vijay Simha.
Thank you, sir. I'll just share my screen. Are you able to see my screen, sir? No.
No, still not.
How about now?
Yeah, now visible.
So, good evening. The topic that I have chosen to speak today is about HER2 positive breast cancer, especially with a focus on dual HER2 blockade, that is trastuzumab plus pertuzumab, and how it paves the way for managing breast cancer in India. So we all know that now breast cancer in females has become the #1 cancer, and also not only is it #1, but the incidence is also rising very fast. For example, the incidence in from 2015 to 2025, almost we can see from the ICMR data that there is almost a 40% increase in the incidence over the last 10 years. So if we see the incidence of HER2 positivity, on an average, around 20 to 25% of all breast cancers are ones which are overexpressing the HER2 protein, and they stand to be treated with the HER2 targeted therapy. So this talk is to just give a glimpse of the present landscape of management in different settings, for example, neoadjuvant, adjuvant, metastatic setting, and also what the future holds for, especially with dual HER2 blockade use in breast cancer. So if we see the neoadjuvant therapy for HER2 targeted cancer, you know that now we know that most of the HER2 positive patients, anything above CT1N0 is going to be going to go towards a neoadjuvant approach compared to the conventional like high tumor volume to breast ratio. But just a HER2 positivity itself and the tumor size being T1, so that itself is an indication for neoadjuvant chemotherapy. And we all know that with neoadjuvant chemotherapy, the best way to go forward is to add a dual HER2 positive blockade. So the data for dual HER2 positive blockade neoadjuvant setting comes from the Neosphere and the Trifina study. Both have shown that if we combine the trastuzumab, pertuzumab, and also the taxane, it results in the maximum amount of pathological CR. And it is depicted in these bar graphs where we see that the combination of trastuzumab and pertuzumab along with chemotherapy has the maximum pathological response rates in both the Neosphere and the Trifina study. And irrespective of ER positivity or negativity, the PathCR rates were higher when trastuzumab and pertuzumab were combined. And we all know that ER positivity in a way drags down the rate of the PathCR. But nevertheless, if you want to get the maximum PathCR, which in turn correlates with the survival outcomes, I think the best regimen to go ahead with is with the neoadjuvant trastuzumab, pertuzumab, and a taxane. And also we use the TCHP regimen, which has which has sort of become the established standard of care. And if we see the NCCN guidelines, in general, in the latest guidelines, they have sort of done away with the anthracycline-based regimens, and the TCHP is the preferred regimen in the neoadjuvant setting. Now, what happened in these studies? They observed that even without the use of the chemotherapy, just with a combination of the pertuzumab and trastuzumab, there were some patients, around 16% of the patients in the Neosphere study, who had developed a PathCR. So taking that forward, there is a new study that is called as the Fergain study. So this study attempts to see if patients could be chemo. It's a chemo de-escalation strategy, just like how we have learned from Hodgkin's lymphoma that we do a total body PET scan after 2 cycles of treatment. There are 2 arms in which one of which is the standard TCHP. The second one is just a chemo-free arm, which contains pertuzumab and trastuzumab with or without endocrine therapy if it is ER positive. And toward the duration of 2 cycles, this is administered. And then we do a total body PET scan. And if the response is good, then we continue with the same regimen for 6 cycles and go on to surgery. And if the patient develops PAT-CR in the chemo-free regimen, then the patient will continue to undergo maintenance without the use of chemotherapy. So this is one of the experimental arms. However, if there was no response in the PET-CT, so then the patient will then receive the standard TCHP followed by the 1-year completion of maintenance with trastuzumab, pertuzumab. So in this study, it was seen that patients who had a response after 2 cycles, majority had responses, almost 80% in the after the first 2 cycles. So only around 20% did not have a response. And more interestingly, if we see the pathological complete response, almost 37.9% of the patient had pathological complete response, where in those who had a chemo-free approach. So they have hypothesized that almost 1/3 of the patient can be given chemo-free regimens and achieve the same 3-year invasive disease-free survival, which is comparable to the chemotherapy arm. So almost 1/3 of the patients of early or locally advanced breast cancer may probably be spared of the chemotherapy and only going on to dual HER2 blockade and endocrine therapy. So the use of dual HER2 blockade so as to achieve quick response in the neoadjuvant setting is an important aspect. And this did not compromise the survival, which was impressively high, a 3-year invasive disease-free survival of 98.8% amongst those patients who had a PET response. And 1 out of 3 patients could be omitted chemotherapy. So what about dual HER2 blockade in adjuvant therapy? We all know the affinity trial and the use of pertuzumab post-surgery who has undergone an upfront surgery compared with the placebo with trastuzumab. We saw that the overall survival at 8 years, there is a marginal benefit which is amplified in those patients who are node positive, where an absolute survival difference in those patients who are node positive was almost 4.9% could be demonstrated in this study. So this gives us solid evidence to use dual HER2 blockade in the adjuvant setting. Most of the patients who undergo upfront surgery for HER2 positive breast cancer end up to be node positive, and this study gives us good evidence to practice dual HER2 blockade in those patients who are receiving adjuvant treatment. And this was added in 2025 that even those patients who are node negative and had a tumor size more than 1 centimeter, that is P, T2, T3, would also preferably receive adjuvant trastuzumab plus or minus pertuzumab, especially in those with P-T2, T3. So there is another trial which adds more confidence in addition of dual blockade to HER2 positive in those patients who have been upfront operated, and that is a Peony trial. It was an Asia only trial where they give 4 cycles of neoadjuvant THP and versus taxane and trastuzumab. So in that, after 4 cycles, they were able to demonstrate that use of an additional 13 cycles of pertuzumab in the adjuvant setting, that is the use of 4 cycles in neoadjuvant and 13 cycles in the adjuvant setting, resulted in a superior 5-year disease-free survival, and also that resulted in lesser distant metastasis-free survival in those patients who had pertuzumab. So what does the future for adjuvant HER2 positive breast cancer hold? Now we know that most of the patients who are undergoing neoadjuvant chemotherapy, and we have to usually follow the Catherine paradigm, that is whether we give TDM1 to anyone who has residual disease. But is TDM1 good enough to prevent all recurrences in those patients who have residual disease after neoadjuvant chemotherapy? Destiny Breast 05 is the study which is going to answer this question, where it is comparing on those patients who have residual disease after completion of neoadjuvant chemotherapy. It could be either a single trastuzumab or a dual trastuzumab pertuzumab, randomizing it into trastuzumab plus deruxtecan versus the standard of care which is established by Catherine study of TDM1. So this is going to give us the answer as what would be the best what would be the best HER2 targeted approach after in those patients who have residual disease after completion of neoadjuvant chemotherapy. Another study is the COMPASS HER2 study, where tucatinib is being added to TDM1 to see if it provides a better invasive disease-free survival benefit compared to continuing TDM1 alone. What about metastatic breast cancer? We all know that Cleopatra study has established dual HER2 blockade as a standard of care in metastatic HER2 breast cancer with an impressive overall 5-year invasive disease-free and also overall survival. And benefit, we often see it ourselves when patients who are on this trastuzumab plus pertuzumab combination go on to receive this targeted therapy beyond 5 years or more. So there are several other options which are available in those patients who have progression after this Cleopatra regimen. That is, the main differentiator is whether there is active CNS metastasis or there is no active CNS metastasis. Now, TDXD is the one drug which has the maximum intracranial efficacy. So it is sort of on par with the combination of tucatinib, capecitabine, and trastuzumab, which is again a dual way of targeting HER2, and both have excellent intracranial efficacy. Versus in those patients who have no CNS metastasis, TDXD would be probably the preferred drug. And on progression with TDXD, maybe tucatinib with trastuzumab, pertuzumab, maybe the other preferred drug. And in the future lines, ongoing with other therapies like use of CAPLAB, trastuzumab, lapatinib, and margetuximab, and other newer drugs. Now, what does the future hold for? Now, there was a randomized trial which showed that use of eribulin in the place of taxane, according to the Cleopatra study. So, if we substitute eribulin in the place of docetaxel, and continue with the trastuzumab pertuzumab combination in those patients who had de novo metastatic HER2 positive breast cancer, it was seen that the outcomes were pretty comparable. That is, the median progression-free survival in eribulin versus the taxane were almost equal. We showed that as long as you have the dual HER2 blockade, it doesn't matter what the chemotherapy backbone is. Even taxane, which acts similar to eribulin, which acts similar to taxane on the microtubule pathway, could also give equivalent results compared to docetaxel. So what another advancement that we may actually see, actually the results were presented in the ASCO 2025 this year, is that the combination of TDXD with pertuzumab. So TDXD with pertuzumab did show good results, but I think that the rate of pneumonitis was very high. So Destiny Breast 09 is a study which compared TDXD versus addition of pertuzumab or the THP, which is the Cleopatra study. So these patients were randomized in a 1:1 ratio just to see what was the efficacy of the addition of pertuzumab to trastuzumab. And I think it was positive in that the addition of pertuzumab plus to TDXD resulted in better progression-free survival. However, in a big way, that is in a landmark practice-changing way, so far none of these regimens have shown great clinical benefit compared to the Cleopatra regimen, which was almost a decade ago. And trastuzumab, pertuzumab with docetaxel continues to be the standard first-line therapy in HER2-positive breast cancer. Now we have a pertuzumab biosimilar, which has been made available to our patients. When I was going through the data on trastuzumab, it has been studied in a systematic way in the Tata Memorial Hospital that trastuzumab was approximately launched in around 2003 by Roche, but even as much as 2023, the utilization of trastuzumab has not been 100%. There was a significant lag. Even when the trastuzumab was first launched in India, only around 8% could afford trastuzumab, and that number only improved to around 15% by around 2015 and 16 when the generics of trastuzumab, biosimilars of trastuzumab were released. And even in 2023, it has become difficult to see 100% utilization of a basic drug like trastuzumab. But however, with pertuzumab, I don't think it is following the same trajectory because right from the launch of pertuzumab, because of its more affordability, the pertuzumab biosimilar is being utilized at a higher rate than what trastuzumab was used. That is because already trastuzumab has established the track record of good efficacy, and now we know that dual blockade is going to be more efficacious. So I think physicians are more comfortable, and I think within the next decade, I think we are going to have a utilization of pertuzumab biosimilars in almost 50 to 60% compared to trastuzumab, which did not achieve these same results. So there was a randomized trial also, which was presented, which has been published, which compared the efficacy, safety, and pharmacokinetics of the pertuzumab biosimilar with Perjeta in those with HER2-positive breast cancer. Is coming right from our own country, and it showed that it is equivalent to the innovator pertuzumab. So what to conclude from all this data? Most importantly, HER2-positive breast cancer is very easy to treat if you have the access to the right drugs, the trastuzumab, pertuzumab, TDM1, and now even TDXD. And eligible patients who are to be planned for neoadjuvant treatment should be preferably targeted with a neoadjuvant first approach. There is also potential for de-escalation strategy, and that is definitely going to become the standard of care, just like Hodgkin's disease, cancer. And post long-term data of pertuzumab in adjuvant setting, if ever a patient inadvertently undergoes surgery upfront, so definitely we have a pertuzumab as a dual blockade in adjuvant setting. And as far as metastatic setting, we know that the Cleopatra regimen, as of date, remains almost the undisputed standard of care. And ongoing research may pave the way for newer strategies like Breast05, which is the best adjuvant HER2 targeted therapy in those with residual disease, 09, and also Compass HER2. Thank you so much.
Yeah, thank you, Dr. Vijay. And what is your experience as compared to the original versus generics?
Sir, I think we are seeing the same rate of PATs, sir. And also the clinical response. Basically, most of our patients are, we say, they respond very well within the first 1 or 2 cycles. Rarely have I felt an inferiority of the biosimilar, sir.
Yeah, I agree. I think
more accessible, and because of the PAP support, it is more importantly, it is coming under the insurance capping of most of the patients who have around 5 to 10 lakh insurance. They easily can go for a dual or 2 blockade.
True, I agree, and especially with Zydus coming up with a plan that even after neoadjuvant, if there is no PAT-CR,
correct, they give the TDM1. Yes.
Yeah, we are also, I think,
yes.
it's a wonderful scheme. Thank you, Dr. Vijay, for the wonderful talk. So the next talk will be mine. It is in the supportive care. So let me share my screen.
So stop broadcasting.
Yeah, thank you. The screen is visible.
Yes, sir. Moving.
Yeah, thank you. So I thank Glenmar for giving this opportunity. So in the next 15 to 20 minutes, we'll just see how the chemotherapy induced nausea and vomiting we manage and how the newer drugs have changed our line of management. So whenever we discuss in oncology with the patients regarding what is the fear they have with chemotherapy and what do they feel whenever we discuss, let us see. If you see, nausea and vomiting is a very dreaded fear what patients has because whenever the patients we discuss, they have their relatives who had the experience of nausea, vomiting, hair loss, and at that time the supportive care was not that good. But presently it is not the case scenario. How it has changed, we will see. So if we ask the patients to rank chemotherapy into nausea and vomiting, we can see here uh, they rank very high. So in their ranking, whatever they feel that they are going to die, nausea and vomiting is almost similar if we see the curve here. So that means it is a very significant side effect what patients perceive. So how we can overcome that one? By appropriate counseling. As we all know, the definitions of nausea and vomiting, acute nausea and vomiting, and delayed nausea and vomiting. So the development of delayed chemotherapy induced nausea and vomiting is a very significant problem than acute. Because for acute, generally our regular drugs will help. But for the delayed nausea and vomiting, the medications what we use, especially this Perinorm or MSET, uh, these medicines will not help because of the shorter half-life. So what by not using these drugs like aprepitant, fosaprepitant, though the acute problems are solved, the delayed problems will not be solved if we don't use this aprepitant or fosaprepitant. And next we will see the next generation of drugs. And this is very important. The first cycle is a very strong predictor how the patient will tolerate. If the patient tolerates the first cycle very well, then the subsequent cycles, psychologically, they will be more confident. So, appropriate counseling in the first cycle, appropriate usage of pre-medications, medications for nausea and vomiting in the first cycles are very important. So, these are the neurotransmitters involved. Coming to some of the important landmark developments in the supportive care. If you take in chemotherapy induced nausea and vomiting, what has changed? Two, three drugs have changed our practice. One is the oral NEPA. So it is the only fixed combination antiemetic. It is a NK1 receptor antagonist. It selectively blocks neurokinin type 1 receptor, and by blocking this one, we can see both subacute and delayed nausea and vomiting will be averted. It has got a very high binding affinity and longer half-life. That is how we can prevent the delayed nausea and vomiting. Coming to one more drug, that is the IV NEPA, how it is easier or better as compared to the oral NEPA. It is also the next generation NK1 receptor antagonist. It is a combination of similar fosnatripitant with pelnocetron. So pelnocetron blocks the 5-HT3 and fosnatripitant blocks the NK1 receptor. So by blocking both these, the synergism will increase. If you see the NCCN guidelines also, this is a category 1 recommendation for all moderate and highly emetogenic drug protocols. So even the present NCCN guidelines clearly states that The present NCCN guidelines clearly states that this is a very important regimen to go. Coming to some of the unique points of this IV Akynzeo. So how it is easier? The one thing is we can say it is a fixed drug combination. So no need to reconstitute. So many of our infection rates, the risk of contamination will be avoided. It doesn't require any surfactant or emulsifier. It minimizes the infusion related toxicity. We can add dexamethasone to this drug. So again, the convenience will be more. We have got Indian data also. If you see the landmark trials, so published by various authors, and see the results here. The complete response in acute, delayed, and overall, they're all above 90%. So if we don't use this NEPA, we don't see this amount of responses. Again, we can see here the complete responses compiling all the Indian authors. Clearly, it has shown a very good response to the tune of more than 90 to 95%. So these are some of the articles published. If we see the article published in JCO of chemotherapy-induced nausea and vomiting, here 354 patients were analyzed and they were all highly emetogenic regimens. And if we see the results again of moderate and severe nausea, more than 95% achieved, both in acute phase and delayed phase and overall phase. So NEPA was found to be effective and well tolerated in preventing nausea in patients receiving moderate and highly emetogenic regimens, even in real world Indian setting. Coming to the various clinical trials, and if we see the publications which have been published between 2018 to 2022, they were all phase 3 study, large studies. And if we see the results, again, the results are very good and the achievement of complete responses at the tune of 90 to 95%. So what does the Cochrane review says? Again, it's a meta-analysis of 73 studies, which again concludes that NEPA, which can be oral or IV, whichever form we give, the results are better and beneficial to the tune of more than 90 to 95%. And these are again some of the real world studies where the earlier studies we saw with anthracycline based, here it is, they are all platinum based. And again, they conclude that NEPA is safe, effective, and cost saving. So to conclude, what we can see, so although the protocols have evolved in the last 4 decades, in terms of supportive care, there were very minimal improvement. But with the availability of NEPA, that is IV and oral, the scenario has changed. And we have got real world evidence and Indian evidence to say that this 4-drug combination should be the pre-medication of choice in our set of patients. So with this, I will conclude and I will thank the organizers and the speakers and the audience. And I thank AstraZeneca, Zydus, Shilpa Diagnostics, and Glenmark for sponsoring these sessions. So thank you all for joining us.
Thank you, sir, for the wonderful talk. Technical team, please close the webinar.